Subclinical hypothyroidism, an important topic for the medicine residents, both in the OPD and also in your exams. What is the subclinical hypothyroidism? It's nothing but patient's thyroid hormone level in the blood, that is T3 and T4. Free T3 and free T4 level is normal, whereas TSH, the thyroid stimulating hormone level, is borderline elevated. So this is subclinical hypothyroidism. Clinical or overt hypothyroidism means patient grossly having thyroid hormone deficiency for some or other reason. Patient is having symptoms, we will treat. That is clinical or overt hypothyroidism. Subclinical means the hormone level is normal. Most of the time patient is not having symptom. The TSH is borderline elevated. What is borderline elevated? The normal TSH, if it is more than 10 milliunits per liter, more than 10, it is an overt hypothyroidism. Hypothyroidism is significant and have to be treated. With the normal level or low level, whatever it is, if it is elevated, that means primary hypothyroidism. The situation have to be treated. Normal is approximately less than 5 milliunits. Less than 5 is normal. More than 10 is abnormal. If this TSH level is between 5 to 10, that is borderline elevated on the background of normal T3 and T4, the TSH is elevated. That is called subclinical hypothyroidism. So what are the other names? There are various names which has been used in the past to describe this condition. One is pre-tibial or preclinical. It is not pre-tibial, it is preclinical. Preclinical myxedema, they used to describe. Compensated hypothyroidism. Yearly clinical hypothyroidism. These are all the terminology we are not using now. Preclinical myxedema, compensated hypothyroidism, yearly clinical hypothyroidism we are not using. And one more terminology they use is mild thyroid failure. Mild thyroid failure. It's not totally or moderately or severely involved, only very mild. The hormone levels are maintained at the normal level, but the compensatory mechanism or the stimulatory mechanism is increased. These kind of names, if it comes in the exam, don't get confused. It is nothing but subclinical hypothyroidism only. Mild thyroid failure, preclinical myxedema, compensatory hypothyroidism, yearly clinical hypothyroidism. These are all the other names. So what is it? It is nothing but elevated TSH level, borderline elevated between 5 to 10 milliunits with normal free T3 and T4. It is called subclinical hypothyroidism. Simple. Symptoms in that category of what is it? Symptoms may not be there. If they ask what is it? TSH 5 to 10 in the category with normal free T3 and free T4. This is what subclinical hypothyroidism is. Then coming to the next heading, what are the causes? Any condition which is causing hypothyroidism can cause this also. Drugs, some kind, radiation, goiter, these usually causes overt hypothyroidism, but the beginning stage can be causing subtle hypothyroidism. In some general population, even the age group more than 35, the general population itself is prone due to various reasons. So causes related to all the causes of overt hypothyroidism will be here also, like autoimmune, goiter, low iodine intake, radiation, drugs. These are all the few to name. Okay, so causes, nothing much to discuss. The most important one, When to treat? So what will happen if this TSH which is elevated not treated? There are three outcomes which can happen. Spontaneously, it might come back to normal over a period of 3 months or 6 months in the follow-up, or it might progress to overt hypothyroidism, or it might maintain in the same range. There are three possibilities. Around 50 to 60 percentage, considering the other parameter, if it is a middle-aged male, no other common, usually it becomes normal. Nothing much to treat, just keep the patient in follow-up. 3 months or 6 months once you have to get the TSH level done and you can decide. But the catch is, why only TSH? You have to look for some parameters before deciding. What are those? First we will see when to treat. Whenever there is a progressive elevation in the TSH over a period of time. If the TSH is getting elevated or ranging above 10, the patient is overtly hypothyroid, you have to treat. So first, when the TSH is progressively getting elevated. The second one, if goiter is there or anti-TPO antibodies are positive, or if the patient is having goiter. Second one. Third, if the patient is or the female or the person is pregnant, pregnancy hypothyroidism have to be treated very vigilantly. TSH target is approximately less than 2.5, trimester wise it will vary, but pregnancy in newborn less than 1 year, we have to treat it. And apart from that, when the patient is having dyslipidemia, lipids are, if it is high. Fifth one, when there is other comorbidities like CAD, if the patient is having gross symptoms related to the hypothyroidism like fatigue, if all other reasons are sorted out, like if anemia is not there, patient is having fatigue, constipation, all other features of hypothyroid, if the patient is having, that have to be, after ruling out other etiology, if the patient is having significant complaint for the hypothyroid symptom, the treatment have to be started. If you think CAD, the risk is high, patient is having multiple other comorbidities, the treatment have to be started. And also considering the age and the CNS manifestation. Another one is CNS manifestation. Patient is having lot of mood swing, psychiatric manifestation. If the etiology, other etiology is not there, if the symptoms are attributed to these kind of mild hypothyroidism, then it should be started. And the age. In the old age, usually we avoid the treatment. So these are the conditions you have to treat. Mostly look for anti-TPO antibodies. Goiter, pregnancy, newborn, dyslipidemia, TSH, if it is progressively elevating. Suppose if these are not there, no need to treat. In the OPD, one important point I want to tell is related to fatigue. Patient might be saying fatigue, but don't jump and start L-troxin, because subclinical hypothyroidism mostly, or especially in a middle-aged male, mostly it resolves to the normal range. If other parameters are normal, keep the patient in follow-up. So this is related to when to treat. Here, one point I want to add is, according to the guidelines, age more than 35 years, every 5 years thyroid function test in the routine checkup is recommended. Suppose if TSH is elevated, you first in the OPD, the common practice wise, first ask why that particular test was done. If it is a part of routine evaluation, just to keep the patient in follow-up, no need to jump and treat. Only if you find rising TSH, anti-TPO, goiter, pregnancy, a comorbidity like coronary artery disease, fatigue, constipation, hypothyroid manifestation in the form of neuropsychiatric issue, then consider treating. And also one more thing is, if the patient or the your pregnancy only. I hope while discussing pregnancy, when I say pregnancy, suppose if a couple is planning for baby, during that time fertility issue, this hypothyroidism have to be treated. So these are all the important situation where you have to treat it. Other than that, no need to treat. So this is the most important one. As a medicine PG, you have to be aware in the first year and second year. And with respect to fatigue, most of the time patient might not require, and if the age is more than 65, mostly keep the patient in follow-up because they might not tolerate the drug. So what is the starting dose of L-Troxin? Ranges from 1.2 to 1.6 microgram per kg. This is the theoretical dose, but most of the time for the mild elevated TSH, we always start with 25 microgram per day. It have to be given before the breakfast. So those are that treatment related stuff we can discuss during the hypothyroid discussion itself. With respect to this, at least remember this dose. The follow-up TSH after starting, it should be after 6 weeks, then after 3 months. Suppose if patient TSH over a period of time, if it is in the normal range, this drug can be discontinued also, taking into the parameters, other comorbidities, why it started, how is the symptom, how is the TSH response. For a period of time, if it is good, yes, it can be stopped. So this is more important. So to conclude, we'll conclude with this flow chart. So what is subclinical hypothyroidism? TSH borderline elevated 5 to 10 with the normal thyroid hormones, free T3 and free T4 is normal, is subclinical hypothyroidism. Why this is a summary slide? When to treat, for that is the summary slide. So whenever there is a high TSH with a normal T3 and T4, if it is more than 10, you have to start the treatment. Start the treatment 1.6 microgram per kg, you have to start. If more than 10, there is no doubt in starting the treatment. If it is less than 10, look at the age. Less than 65, more than 65. More than 65, usually keep the patient in follow-up. The treatment is so significant and probably a lower dose of 25 microgram might be required. What might be the symptom? Constipation, neuropsychiatric manifestations, fatigue. If unexplained by any other cause, then you can consider mostly patient might not require because they might not tolerate the L-Troxin treatment. Here, if the age is less than 65, then you might need to start the treatment. When to start? If anti-TPO antibody is positive, goiter is there, if there is a serially rising TSH level, dyslipidemia, lipid parameters is very important. If there is a high cardiovascular risk, hypothyroid symptoms, weakness, constipation, neuropsychiatric manifestation during pregnancy, or if the couple planning for a baby. These are all the situations where you have to treat, otherwise keep the patient under follow-up. So this is all regarding the treatment. When to start, so we told what is the dose? 1.6 microgram per kg per day. 1.2 to 1.6, 1.6, 25 microgram. For a period of 6 weeks, look at the TSH and the level have to be titrated up. Titration 12.5 to 25 microgram at a time you can do, then subsequently you have to follow up. So this is all regarding subclinical hypothyroidism. I hope you understood what is this. Bye-bye. And as a disclaimer, which was supposed to be told in the beginning, see these videos are for MD residents who are already MBBS doctors. So these are not for general population. So these are not for treatment purpose. Okay, these are the only for doctors who know at what context this is being discussed. So don't please don't comment asking for the treatment suggestion and queries as we are getting in the previous videos. So this is the disclaimer for this video. Bye bye.